In terms of what we're going to be discussing, basically the summary of all this, number one, overall, cancer survival is trending upwards. And I'll show you the data, but over the course of the last 15, 20 years, there's actually been a significant improvement across the board. All comers, all stages. Obviously, earlier stages are easier, relatively speaking, to survive as opposed to the later stages. But across the board, stages 1 through 4 in oncology, we're seeing a significant improvement in terms of response rates, survival, longevity. Checkpoint inhibitors in particular has been much more actively used now compared to 10 years ago. When I first started doing oncology 20 years ago, because I am seasoned, so 20 years ago, we didn't really have that. It was maybe beginning to be evaluated in the laboratory. And so it's in the last 15 years that it's become a lot more active, first in difficult to treat cancers like melanomas and renal cell cancers, which historically just never responded to chemotherapy, but over the course of the last 10 years in other cancers as well. And so the use of it has exploded, really, over the last 10 years. Because of that, and because we've been using it more and more now, we're also finding chronic toxicities. Even after the patients are done with therapy, there can be lingering side effects. And so the more we see them, the more we have patients that have them long term, we're seeing a lot more of these chronic side effects, and we need to really know how to deal with them. Again, also because more and more people are living longer, either on active therapy or longer because they received checkpoint inhibitor immunotherapies in the past and had a good outcome from it. So this is kind of a survival curve that starts in the mid-1970s, going up to about maybe 3 or 4 years ago. As you can see, the general shape of the curve is upward. This is overall survival from cancer. This is looking at male, females, both sexes, across the board. This is what I was talking about over the course of the last 40 years, but as you can see, it's pretty consistent, thankfully, rise up. The 5-year survival, if you look from 1995 to 2025, so over the course of the last 30 years, overall survival, meaning how many people are alive 5 years after diagnosis, which is sort of our surrogate for cure. I mean, there's caveats to that, but if you can go 5 years without a recurrence, in general, people do pretty well and don't have a recurrence down the road. Most cancers, if they come back, have a higher likelihood of coming back within those first 5 years after diagnosis and treatment. So if you can go 5 years, again, it's never 100%, but you feel pretty good that you got most of it. So that's been a surrogate for essentially cure. So cure rates basically have been up from 63% in 1995 to 70% in 2025. 7% is a real number. We're talking about tens of millions of people that have had improved survival during that time. Overall, the cancer deaths have decreased by 34% since their peak in 1991. Meaning that cancer is the main source, a cause of the death for most folks. So about a third less people are dying of cancer now as opposed to 30 years ago. And the reasons for that are many. It's not just therapy. Probably the number one cause is people are smoking less. If you look at the actual numbers of people who are starting smoking, continuing smoking, there's a lot less now. A bit of an uptick in the last few years, but mostly it's with things like vapes, which have their own issues, but maybe less carcinogenic in general. But bottom line, if you look at the number of people who are smoking in the 1960s and 70s versus the ones that are smoking now, significantly less. And that has resulted in an improvement, not just lung cancer. We always associate, smoking with lung cancer, and definitely there's an association, but across the board, breast cancer, bladder cancer, colorectal cancer. All these things do tend to have a higher likelihood in patients who are smoking, just because smoking just increases your risk of mutations, increases your risk of carcinogenesis. Other things, early detection. We have a lot better ways of detecting and screening for cancers now. In the 80s, that was mammography, which was huge. That basically made it so that back then, women who were being diagnosed with breast cancer were being diagnosed in the early 80s as stage 2 and stage 3. Still curable, but harder to cure. Now, if you're diagnosing them at stage 1 or even stage 0 because you're doing screening, a lot more likely that you can cure them with our current standards of therapy. Same thing is happening, colorectal cancer. The standard is now screening colonoscopy starting at age 45. That has detected quite a lot of precancerous or early cancers that are being more likely to be cured. Things like cervical cancer screening with Pap smears, PSA, with all the controversies it has, does result in significant improvement in terms of at least earlier diagnosis. And then around 2011, we started seeing that lung cancer screening. Since lung is the most prevalent cancer in the United States, lung has more cancer diagnosed than the next 3 combined. So lung is number 1, then there's breast, prostate, and colon. Those 3 combined actually have less cancer diagnosis per year than lung. So the fact that we were able to find a good screening for lung cancer starting in 2011 has made a huge difference over the course of the last 20 years or so. And of course, improved treatment. Beyond just immunotherapy, we have targeted therapies. Nowadays, for a lot of cancers, we're able to find what are the genetic markers that are changing that we can target and treat, so that way we don't just kill everything like we do with chemotherapy. Very effective, but also very toxic. Now we have a lot better, potentially, in the proper setting, treatments, of which immunotherapy, checkpoint inhibitor immunotherapy, are a huge improvement or a huge step up in terms of that. So because of that, you have a lot more people that are living with cancer. So this is a breakdown of how of patients in terms of how many are currently in existence, meaning their prevalence with cancer or have survived cancer. So as you can see, a vast majority, so the blue and the red there, the blue is 65 to 84 years old, red is 85 or greater. So we're looking at, frankly, with the exception of testicular cancer and maybe thyroid cancer, pretty much all the other cancers, more than 50% of patients with cancer, either as an active cancer or history of, are over the age of 65. And they're living longer, mostly because the treatments that we have are not as toxic. Can you imagine giving somebody who is 80, 85 years old, pretty toxic, platinum-based chemotherapy? I mean, they can probably do it for a time or 2, but you have to stop it pretty quickly, and because of that, they're not going to be able to expose themselves to appropriate treatment. Now that we have targeted therapy, now that we have immune therapy, people are living longer. More importantly, they can handle the treatment longer. They don't have to stop early because the side effects are too much. And so because of that, thankfully, we're creating a really significantly greater population of survivors. And many of them are 65 years old or older. And so they need to deal with the toxicities of the treatment along with any other medical conditions that they have, including things like high blood pressure and coronary disease and diabetes and those kinds of things. So it's part of the overall sort of package of taking care of patients with a history of cancer, but also in the elderly and geriatric population. All right, as far as checkpoint inhibitors, so I'll talk more about how they work, but basically their use has been increasing, like I say, exponentially really over the course of the last 10 years. Over the course of the past decade, real-world utilization rates back then have increased from 15 to 62%. So I mean, considering that we have other treatments as well, there's surgery, there's radiation, there's chemo, there's targeted therapy, there's everything else, these are being used at a significant proportion in our active cancer patient population. Nowadays, about a little under half of patients are considered eligible. Not everybody is expected to benefit from checkpoint inhibitors, but more and more we're finding out that a lot of people are able to do it. There's controversy as to how to identify, but basically there are molecular markers that exist in some cancers, not all. This thing called PD-L1 or PD-1, which are the targets for these checkpoint inhibitors. A lot of cancers express those particular molecular mutations that would make them more likely to respond to inhibitors, as opposed to things like targeted therapy. If you might have heard of things like Tarceva or Tagrisso for lung cancer, yeah, those are great. However, they only exist, depending on what you look at, somewhere between 5 to 15% of all patients with cancer. So they can help those who they are targeted against, but the number of patients that are targeted are a lot less. Others are even less than that. Probably that's the most common. We're talking about incidence rates of 5% or less for a lot of these targeted therapies, whereas with checkpoint inhibitors, somewhere around 45% of those patients are able to be eligible and can therefore receive it, and so can benefit from it. And then once they get them, the response rates are pretty decent. Across the board, when they were first studied, were studied in stage 3, stage 4 cancers. Even in patients who have been multiply pre-treated, they were still getting 10 to 25% response rates, which is pretty decent considering somebody's been exposed to multiple treatments already. In melanoma in particular, which again historically has had a difficult time being treated with chemo, melanomas didn't respond to chemo. Even when we were giving them high-dose chemo with stem cell transplants, we were using things like interleukin. I don't know if you guys remember those kinds of things, just because there was nothing else to use. In melanoma, we're seeing upwards of 70% response rates. And that's why melanoma is probably the first one where there was really a lot of information and breakthrough with these checkpoint inhibitors, because they were the sickest patients with the least options available. And then what we found is they work there. Thankfully, they didn't only work there. They worked in other cancers as well. For instance, looking at a more recent PubMed article, ICI, immune checkpoint inhibitors, ICI, utilization rate increased. There was 91 prescriptions in 2011 and over 462,000 by 2021. So over the course of 10 years? No, 20 years. It went from 91 to over 500,000 actual prescriptions. I bet you it's probably more now. That was like 5 years ago. So. And then because of that, at a cost of about $4.1 billion. I'll show you the data here in a little bit. And also, again, because these are not as toxic as chemo, the average treatment duration is longer. Chemotherapy, we're lucky if we get anywhere between 4 to 6 months of therapy. Even if chemotherapy works, often we have to stop, because you got low blood counts, neuropathy, weakness and fatigue, other kinds of side effects. Even if they work, you have to stop after a while. And then, of course, when you stop the treatment, sure, the patients feel better, but then the cancer is able to grow. The good thing with immunotherapy is, I mean, they're not, again, not non-toxic, but because of the decreased intensity and frequency of toxicities, we can keep them going for longer. 10 months, 20 months, that's almost 2 years worth of therapy, which means it was working for 20 months, if not longer, and it was being tolerated pretty well. And often, even after you stop immunotherapy, the effect of it can linger. So even though you're not getting active therapy, they're still preventing the growth of the cancer. So for all of these reasons, we're using them more commonly for a prolonged period of time. Like for instance, this is in patients with non-small cell lung cancer. That PD-L1 is the molecular test that we can use, not always, but we can use for whether or not to tell whether a patient will respond to it. And we're talking about patients who are being treated with it with improved 5-year outcomes. That's essentially cure. So these are patients with metastatic cancer. So when we're talking about metastatic cancer, just kind of put in perspective, okay? I guess I've seen this evolve in my career. If a patient is diagnosed stage 4, lung cancer, non-small cell lung cancer, without treatment, okay, the average life expectancy is about 6 months. With chemotherapy, back in the day, 11 months. The big deal was when we added chemotherapy in this medication called bevacizumab, it became 14 months, so a little over 1 year. Now, with the use of, again, if you have to be PD-L1 positive and you have to be in the proper setting, these are patients that are being treated stage 4 at diagnosis with immunotherapy that are being treated for more than 5 years. So that's obviously a huge game changer. And again, it's not just 1 or 2 people. It's about 43% of the population that has opportunity for this kind of stuff. So just a personal story, I got 2 patients. One was diagnosed with early stage. We treated him, chemo, radiation. He was fine for a year, then he came back metastatic. So we started him on pembrolizumab, which is a checkpoint inhibitor. At some point, after 5 years, the insurance company wanted to stop paying because, hey, this guy has no cancer. He's been doing therapy for 5 years. And to be honest, it was a legitimate question because 5 years, it's kind of, well, do I keep on potentially exposing this patient to toxicity? He'd done well, but he had some minor stuff, knowing that there's no cancer growth. So he and I had a discussion about that. Hey, should we stop? Should we not? And so, it was a good discussion to have because he was doing so well. Another patient, an older lady, she was, I think, in her mid-70s when she was diagnosed with stage 4 small cell lung cancer. If anybody knows small cell lung cancer, those are notoriously difficult to treat. Even if they have a good response initially, usually small cell lung cancers have a high risk of recurrence with standard therapy. She's now 7.5 years into therapy. We started her with chemo, transitioned her to immunotherapy. We figured, we'll keep the immunotherapy on as long as it works and as long as she's tolerating it well. She's now in her early, mid-80s, still doing well. Last CT scan was a couple of months ago, still no evidence of progression. And I'm not going to stop because it's small cell. Small cell really does scare me quite a lot. So these are stories that we never really used to have. And so it's nice to be able to. So we're talking about data, looking at what 5-year outcomes, people who are surviving more than 5 years when they're advanced stage of diagnosis. Same thing within the use of clear cell carcinoma, renal cell carcinoma. Again, they don't respond to chemo. We used to do immunotherapy for kidney cancers. Now we're talking about the same thing, five-year analysis. Talking about the use of neoadjuvant therapy in colorectal cancer. So as you can see, it's not just one cancer, it's across the board. It's more of a disease that we target if you have the PD-L1. I don't care what cancer you have, if you have PD-L1, again, it's not 100%, but there's a much better chance that you'll respond to therapy with a checkpoint inhibitor. So it's really tumor agnostic, and it has a greater reach than other kinds of cancer. And then also, not only that, you've had sustained responses. So even in patients, for instance, with brain metastasis, brain, as many of you know, it's a protected area. There's a thing called the blood-brain barrier, which prevents a lot of treatments, especially standard chemotherapy treatments, from making their way into the brain. We have to rely on things like surgery, brain surgery, as you can imagine, is pretty traumatic, radiation therapy. But now we have some data that several immune therapies are able to make it through the brain and have a significant response. And these are patients, again, obviously stage 4, and are still having prolonged response. And then this is small cell lung cancer. The longer they can be treated, the more likely they are able to survive, not just because you're actively treating them, but even after you stop therapy, the response is maintained. So we have a lot of patients that are being treated, they're living longer, they're being exposed to the therapy longer. And so because of that, we need to be cognizant of the toxicities. Does that make sense in terms of the overall context of all of this? So this is a quick aside. This is the number of prescriptions for checkpoint inhibitors. As you can see, in 2011, there's at 94. When you get down to 2021, 462. It only cost $2.8 million back in the day, and now it's almost $4.2 billion. And so it's expensive. It works, and so that brings up a whole other debate in terms of societal needs, what have you. But in terms of treatment, the reason why we're able to do this is because they're working, and they're working for a long time. In particular, right around here, 2015, 2016, that's when, as you can see, a huge change. It went from 47 million prescriptions to 332. Anybody care to guess what might have happened right around then? The lung cancer data came out, and it became approved for lung cancer. 2 of them, pembrolizumab and nivolumab, became approved for lung cancer. And since lung cancer is the most common cancer in the United States, it started being used more consistently, and it's made a huge difference at that point. So it costs money. It is new, and it's indicative of just how important, I guess, of a milestone that is, both in terms of what it does for the patient on an individual level, but sort of something that we need to discuss as a societal level as well. All right, how they work, basically, what it does is it allows your immune system to identify cancer again. Okay? The way that cancer, not the only way, but one of the ways that cancer is able to grow in the body is because it's able to convince the immune system that it's supposed to be there. Okay, and what that normally means is that these two right here, the antigen T cell receptor and the PD-L1, PD-1 receptor. Here's your T cell, here's a tumor cell. If these two are, there's a handshake, I guess, if there's a recognition between these two protein systems, then the tumor cell is recognized as a quote-unquote self cell. Your immune system doesn't try to kill it. What the PD-L1 and the immunotherapies want to do is they break up that interaction. That one there is still there. However, it breaks up this interaction, which is the inhibitory reaction. So if you block it, the immune cell is able to recognize that, hey, you're not supposed to be here. I will therefore start an immune response against you. So all of this is a completely different mechanism of action than any of the chemos. Chemotherapies would go to your DNA and they will, destroy your DNA, generate mutations, but it kills everything, both normal cells and cancer cells. This one is able to identify, a cancer cell that's not supposed to be there, and by doing that, it allows the T cell, the body's cell, to kill the tumor cell. That make sense? So the inhibitors, the anti-PD-L1 and anti-PD-1, basically it restores your body's immune system's ability to kill cancer cells. It essentially hypercharges your immune system, primarily against the cancer, but as we'll find in a bit, it hypercharges it against other cells also. So what are those? So on the anti-PD-1 side, the first couple that were approved were pembrolizumab, that's Keytruda, and nivolumab Opdivo. That was back in 2015, 2016. However, all these now have been, these are approved medications in various, not just lung and everything, but in sort of various diseases. So that's, as you can see, there's more of them. And on the other side, the anti-PD-L1 that binds to here, the most common one is atezolizumab and durvalumab. There's a couple others there too. There's actually another one that I didn't put on here. It's called the CTL4 pathway. Similar kind of thing. It blocks a pathway that again, restores the body's ability to mount an immune attack against the cancer. Depending on which one, there might be some differences. Some people have shown that perhaps blocking the, blocking the PD-L1 receptor is not as toxic because there's another one called PD-L2 that kind of mediates some of that too, so it's not quite as toxic. Whereas if you block the PD-1, it blocks every activity, and therefore the toxicities are more pronounced. I mean, maybe. I mean, most likely yes, but it's not realistically as important in a practical sense. What it does do is that it causes increased toxicity at the immune level. Basically, by activating the immune system, the kind of side effects you get are immune side effects. If you've ever gotten chemo before or seen somebody get chemotherapy, the side effects are basically those chemotherapy drugs, they kill everything that grows fast. The way that it differentiates is, doesn't tell a cancer cell from a normal cell, it differentiates a fast-growing cell from a slow-growing cell, and it kills all the fast-growing cells. Cancer grows fast, gets killed. But your normal cells in the body, some of them grow fast enough to get killed off. Your hair, you got to cut it on a monthly basis. So that gets killed off. That's why many cancer treatments and chemotherapies, you lose your hair. The lining of your GI tract, your esophagus, your stomach, your intestines, those are full of fast-growing cells because they're always exposed to the stomach acids. Since your body's got to keep making new ones. So because of that, those cells get killed off by the chemotherapy. And that's where you get a lot of the classic side effects of chemo: nausea, vomiting, diarrhea, constipation. And the third sort of big one is your blood, right? Your bone marrow makes blood cells. It's basically churning out blood cells every few days. So blood is actually a fast-growing organ. And so because of that, chemotherapy kills off blood cells. That's why one of the main side effects of chemo, one of the really dangerous side effects of chemo, is it lowers your blood counts. Your white blood cells are down, your immune system's down. If you have low red cells, you're tired, fatigued, anemic. So those are the typical side effects of chemotherapy. Those are not the typical side effects of immune therapy. The immune therapy side effects are more the side effects of a hyperactive immune system, right? Itises, right? You have inflammation in your joints, arthritis, that's a thing. You have inflammation in your skin, dermatitis, that's something. You have inflammation in your mouth, mucositis, that's a thing. So those are the kinds of side effects that we see with immune therapy, because even though majority of the effect is onto the tumor cell, the other normal cells kind of get, they get sort of peripherally targeted. As well. And that's when you look at side effects of the immune therapy, that's what we see. Again, if you look at it, yeah, there's grade 2 and grade 3 side effects. The more you combine, for instance, the combination of, pembrolizumab, ipilimumab, nivolumab, the two combination together has more side effects than the individual ones by themselves. Makes sense because you're targeting a couple of different things. In general, though, the severity on a case-by-case basis, and the incidence of toxicities are significantly less with immunotherapies compared to chemotherapy. And so because of that, especially in the beginning, we're kind of lulled into thinking, well, just put this stuff in the water, everybody can get it, that way, we'll deal with the side effects when we get it. I'd say that's true for a vast majority of things, but there are significant toxicities that can lead to not just changes in quality of life for these patients, but can be life-threatening. And so I think it makes sense for us to remember that also. All right, so what are those? So what are the acute toxicities? Like I said, anything itis, inflammatory, think of a thing. Iritis. Yeah, you can get inflammation of the iris. Not as common. You can get all that kind of. You can get colitis. You can get, all these things. Sialitis, inflammation of your salivary glands. All of these things can happen. However, the most common acute toxicities, there's a few that we do tend to notice more commonly and are able to deal with more consistently. So probably the most common is dermatologic. Any sort of dermatitis. You can get eczema, you can get vitiligo, you can get just regular, itching, pruritus, those kinds of things. Gastrointestinal is another one. The GI system can be affected by this. Hepatic, liver, we'll talk more about that. Pulmonary, the lung, and then endocrine, so your hormones, thyroid, pancreas, those kinds of things. So those are the ones that we find most commonly are affected. Doesn't mean you got to stop therapy. It just means you have to be paying attention to those because, again, they can be subtle, and sometimes you'll miss them unless you're looking for them. So with dermatologic toxicities, we're talking about things like rashes, pruritus, itching, even the absence of a rash, vitiligo, the loss of melanin, so the discoloration, like a whitish discoloration. More often than not, are annoying rather than life-threatening, but as you can imagine, there are some life-threatening aspects, and we'll talk a little about that. So basically what you do about it depends on how much of the skin is affected. The less amount is affected, you may not even need to change your medication. Like, you can give topical steroids, you can work with even topical antihistamines. The more of the skin is affected and the more severe the toxicities, it might require things like systemic steroids, so prednisone, dexamethasone, and ultimately the withdrawal of the medication. GI, the most common is diarrhea. It just causes irritation, especially of your colon, and so you're not able to retain as much water, so you have patients with diarrhea. Again, mostly mild. You can actually give the treatment for most of these things are steroids because there is immune hyperactivity. So you give medications that can decrease the immune system, of which the most common is steroids. But there's actually a kind of steroid called budesonide that you take it, and it stays in your GI tract. You don't absorb it into the system. So it stays in the GI tract where there's the most toxicity, and you don't have a lot of the systemic side effects of steroids. So there's treatments available for that. Colitis is diarrhea, but with more inflammation, more pain, bloody diarrhea, things like that. And then again, depending on the severity of it, you have different mechanisms of trying to fix it. It doesn't mean that just because you have diarrhea that you have to stop immunotherapy. You try to continue treatment as much as possible. And again, the vast majority of patients are able to continue, but you got to deal with it with something, an antihistamine, a steroid, some sort of immune modulator. Liver is a problem just because the liver, it does so many things in the body, right? Probably the biggest thing that the liver does is it metabolizes drugs. It takes care of toxins. And really, the immunotherapies, even though they're helping us, they're still toxins to your body. So if the liver is not functioning properly, fine, it's already bad because the liver does a lot of good things too, but it takes longer for the drugs to get out of your system, and therefore it prolongs potentially the duration of the toxicity. And you get to see things like increased liver enzymes. You might get some autoimmune hepatitis. Again, the severity of it dictates what you do. Liver is more difficult because a lot of times you really kind of have to stop treatment, at least temporarily, for liver, just because you don't want to keep exposing somebody to a treatment that they can't get rid of because the liver, the main organ to get rid of it, is not working properly. Pulmonary, that's a big one. As you can imagine, things like asthma. If you ever had asthma, the wheezing can be problematic. You can have things like interstitial pneumonitis, where even in the absence of a bronchospasm, you can get difficulty with inflammation in the lung. Again, severity determines what you can do. Lung and liver, because they're pretty important organs. If those things get affected by the immunotherapy, we have a lot shorter leash in terms of pulling the immunotherapy, giving the body a chance to recover. Unfortunately, those are also some of the ones where oftentimes if you resume therapy, the toxicities come back. So that might be a rate or a dose-limiting toxicity. And endocrine, probably one of the more common ones, also the ones that are more difficult to diagnose unless you're checking for it. So most commonly, you're talking about your thyroid. You can get thyroiditis, hypothyroidism, things like that. It can affect your adrenal glands. People can get low blood pressure from that. Pancreas can be affected. You might get diabetes or worsening of an already known diabetic condition. Now, not all of those are the most common. they're not all going to result in discontinuation. However, there are some toxicities that can be severe enough that will eventually result in you having to stop the therapy. Probably the the biggest one, myocarditis. So myocarditis is inflammation of the heart muscle. You can imagine, we don't want that. The heart's pretty important. The good thing is that it's infrequent. Somewhere between 0.5% to 1% of patients exposed to immunotherapies develop myocarditis. However, the morbidity and mortality rate for myocarditis is very high. Depending on which studies you look at, somewhere between 25 to 50% of people with myocarditis will die. And so you don't want to let it go for any longer than necessary. It's very rare, but very serious. And that, if you have myocarditis, pretty much you're done with immunotherapy. You can't do it anymore. It's hard to diagnose because there's a lot of different toxicities to it, of different symptoms. It might be arrhythmia. You have a skipped beat or an irregular heartbeat. You might get some shortness of breath because you're, like CHFs, congestive heart failure type of symptoms. You might get pleural effusion, or like a pericardial effusion. If you look at the X-ray, the heart silhouette gets big, not because the heart's getting bigger, but there's fluid developing around the heart. So the ways it can manifest are different, and there's no set standard in how often to check for it. Some people will say, well, why don't you just check troponins, because those are signs of myocardial injury. You can check this thing called beta natriuretic peptide, BNP. I mean, you can do that, but then, like I said, the incidence of this is less than 1%. So I don't know if you're going to be doing those kinds of tests every time you give treatment to those 4.1 billion prescriptions just to find the 0.5 to 1%. So I'm not sure that's the best way. A lot of it is really just making sure you pay attention to the symptoms and act accordingly. And treatment's the same: steroids and withdrawal of the treatment. Neurologic's a big one. Again, neuro is we didn't even talk about it. It's not very common, but it can be significant, and it can be subtle. Sometimes not. It can be something like encephalitis or aseptic meningitis, headache, fever, visual disturbances. Those folks really need to go to the hospital, and they need high-dose steroids. Again, rare incidence, but very high morbidity and mortality. But it can also be other things. It could be myositis, like our neuritis, inflammation. You can have things like peripheral neuropathy. You can have things like myasthenia gravis or multiple sclerosis type of symptoms, which are much more difficult to diagnose. And so, you just have to be very cognizant of it. In particular, in patients who have had brain radiation or brain surgery, they tend to be more susceptible because the brain is kind of, a little bit injured at that point anyway. But even folks who have never had any sort of CNS treatments can sometimes get that as well. Pneumonitis. So we'll talk about pneumonitis. Most pneumonitis is grade 1 to 2. A little bit of wheezing, you give them an inhaler, they do okay. But there is such a thing as grade 4 pneumonitis, as you can see, where most of the lung, down in the bottom right there, is inflamed, a lot of fluid. There's not going to be a whole lot of gas exchange happening at that point. And at that point, really, these patients sometimes need to be intubated. They need high-dose oxygen. Again, you don't want to risk that. It happens a lot in patients. Unfortunately, we see patients with lung cancer that have had radiation to the lung or surgery to the lung. They are the ones that are more susceptible. And also, these are the ones where even if you keep them off treatment for 2 months or 3 months until they get better, you resume therapy, they have a very high likelihood of having a recurrence of the symptoms as well. Severe colitis, not just diarrhea, but we're talking about hemorrhage, a lot of abdominal pain. Sometimes you can get a place where there's a lot of obstruction and you get megacolon where the colon gets bigger, very uncomfortable, risk for perforation. So, a little bit of diarrhea, fine, not a big deal. I mean, it's a big deal, but not as big a deal. However, this is not just a little bit of diarrhea. This is like the next level and beyond that. Hepatitis, we talked about that. Because the liver is so important in processing drugs, if the liver function diminishes, then you're in trouble, because not only do you not have the coagulation proteins being made and other proteins being made, you can't even clear the drug properly, and the effect lingers for longer. So we talked a little bit about dermatitis, a little bit of a rash, right? This is the exact extreme of that. If you guys ever seen somebody with Stevens-Johnson's or toxic epidermal necrolysis, what that means basically is your skin's kind of sloughing off. There's so much inflammation that it's red, it's a lot of cystic changes there, and it can affect a significant portion of your body. And so depending on how severe it is, first of all, you got to stop treatment. But these folks need to be in a hospital. We underestimate how much our skin does in preventing infections. If you've ever had a cut that you didn't treat properly and it kind of just festered and got red and stayed longer, that's what it does. If you lose a significant portion of your skin, these are like burn victims. They have loss of a lot of fluid. They have a high risk of not just bleeding, but infections also. Most of the time, there's a progression, but there are some situations where they're fine, and next thing you know, 4 months later, boom, they have an event, and then you just really need to be able to recognize it more quickly. But these are the things that can result in discontinuation of therapy. What we are probably most interested in is what are the chronic toxicities. Again, the ones where the patients have been around for many years, they were treated for it, maybe they're still undergoing treatment for it, but they've been on it for several years now, or they got it before we had to stop therapy because of one of these severe toxicities, and they're still feeling it. Right? And so in the survivorship situation, as we follow those kinds of patients, and they're doing well because the cancer, thankfully, is not growing, we need to deal with the quality of life associations that are affected by these chronic toxicities. Probably the most common one is endocrine. We'll talk more about that. Thyroid, diabetes, adrenal glands. Musculoskeletal, we didn't really talk much about either in the acute or severe. None of these are severe for musculoskeletal, but they can be long-lasting. Neurologic, talking about peripheral neuropathy, and then skin and mucous membrane changes. So hypothyroidism is probably the most common endocrine abnormality. Again, it's very difficult because it evolves slowly, and patients will just feel kind of off, a little tired, maybe a little constipation, not even diarrhea, right? We're worried about diarrhea, but they get constipated. You might get some swelling, some edema. Those are the kinds of things but then you don't really think about it. But then you check a TSH, and then, whereas it was perfectly normal 3 months ago, all of a sudden your TSH, the thyroid stimulating hormone, is through the roof. Again, very slowly evolving thing. Very common, but subtle in this presentation. The good thing is that the treatment is easy, relatively speaking. You give them thyroid hormone back. This is usually not something that will require discontinuation of therapy, but it is something that can linger, sometimes even years after you discontinue therapy for other reasons. And these patients are not uncommonly needing to be on thyroid supplementation for a long time, maybe lifelong, depending. Adrenal insufficiency, adrenal glands, make mineralocorticoids. If that gets affected because of inflammation, you'll lose mineralocorticoids. The way that manifests is in low blood pressure, but also changes in your salt. Your sodium's down, potassium, all that kind of stuff. And so a lot of times you'll need to give them something like hydrocortisone, fludrocortisone, Florinef to maintain blood pressure, things like that. Again, that can be long-lasting as well. Again, usually very well treated, but will need treatment long-term. And then diabetes. Either they didn't have diabetes at diagnosis, but they developed it as a course of their therapy, or more commonly, because these are patients who are older, have other comorbidities as well, they had diabetes, it's probably reasonably well controlled, and then after a couple of years of immunotherapy, it's poorly controlled, and they need more treatment than what they were needing before. Again, manageable, but needs to be recognized so that you can deal with it and monitor it long-term. Musculoskeletal, probably the most common is chronic arthritis. And it's so frustrating, and it's hard, because you don't want to put somebody on steroids for chronic arthritis, but it's not like there's a whole lot others you can do, because it's inflammation of the joints, right? So what you do is you give them pain medication. You give them an NSAID usually, sometimes meloxicam. Oftentimes you'll need to give them, at least for the short term, things like opioids, which are good from a quality of life standpoint, but you don't want to put somebody on morphine for several years. And so it's very frustrating because it's minor in the sense that it's not going to kill them. However, it is something that they'll need to deal with on a daily basis, sometimes significantly. And if you've ever had really bad arthritis, it's not minor. It affects your day-to-day life. When you're walking, you can't. When you're doing your daily activities, it's hard to do. So it's present long-term, again, even after the discontinuation of immunotherapy. Probably the most common neurologic long-term is peripheral neuropathy. Peripheral neuropathy is difficult anyway. Probably the most common cause of peripheral neuropathy is patients with diabetes. Because it affects the peripheral nerves, sensory nerves, either it's numbness or tingling or pain. Same thing can happen in immune situations. If you've got somebody who has already got diabetes as well, it's not an uncommon situation. Their diabetes is out of control, contributes to your neuropathy. The immune therapy also contributes to the neuropathy. And so there's medications for it. Often the treatment is helpful but not complete. Maybe it improves the neuropathy, but doesn't make it go away completely. And as far as skin and mucous membranes go, vitiligo, again, the discoloration of the skin, steroid cream, you can do things like tacrolimus or things like that. Again, not life-threatening, but depending on where it's manifesting, can be affecting quality of life. Eczema, eczema is an autoimmune disease anyway, and that can be either mild, like in your peripheries, or it can be significant. Again, topical steroids, systemic steroids if appropriate. And then the other one is Zika syndrome. It's kind of weird. Affects your salivary glands, and you don't make enough saliva, which seems like a trivial thing until you realize how important saliva is in maintaining things like your dental health. And when you start having dry mouth chronically, your cavities goes up, infection rates go up, and actually that can affect other things like systemic disease too. Like we used to see it a lot in patients who had head and neck cancer, for instance. They got radiation therapy to the head and neck. You would have decreased salivary production, and you got to be seen by a dentist every 3 months, all that kind of stuff. Same thing can happen in patients who have Zika syndrome from immunotherapy. So again, things to think about. A lot of these things, thankfully, are not life-threatening, but can be something that need to deal with long-term. So what does it mean for us in terms of our survivorship model, right? How do we incorporate that in thinking about survivorship? Number one, there has to be ongoing clinical evaluation. That goes without saying. Even if patients didn't have any of this stuff, they'll be seeing their doctor every 6 months at least anyway. People who have completed therapy, have no active disease, you're still doing something, whether it's physical exam or a lab or scans every 3 to 6 months. In the beginning, we see them more closely, like every 3 months for the first couple of years probably, and then less frequently as you get further and further out. But you'll be seeing clinical evaluation, which needs to include some of these symptoms we're talking about. So symptom-based evaluation, you have a little bit of shortness of breath, let's just get a chest x-ray, make sure things aren't happening there. You got a little bit of electrolyte abnormalities, let's check to make sure your adrenals are doing okay, things along those lines. And in particular, when it comes to endocrine stuff, check the labs, because again, those symptoms can be subtle, and if you're not seeing them for 6 months, they can go 6 months and have pretty florid hypothyroidism by the time they come back if you're not checking on a regular basis. You need a multidisciplinary team, depending on what the results are. Like if you have somebody with pneumonitis, they probably should be seen by a pulmonologist regularly. If you have somebody with diabetes, it'd be great if they also saw a diabetic education folks or an endocrinologist. Somebody has chronic arthritis, I don't know, rheumatology might be helpful. Those kinds of things. It needs to be a multidisciplinary effect, because depending on which organ is affected, you want to make sure that there's somebody around who is an expert at that organ as well. Also, make sure there's a quality of life focus. Oftentimes, by the time they get to this point, again, they have good long-term benefits from immunotherapy. They'll be around for a while. And so hopefully, they'll have a good long survivorship time frame, which means we're not really focusing on keeping them alive. Hopefully, that'll be, that's what we did with immunotherapy, but making sure that the quality of their life as they hang around for longer is improved as well. And that means things like more subtle stuff, fatigue management. Somebody who's hypothyroid and can't breathe properly because of pneumonitis, they're going to be tired. And so you want to make sure you deal with that as well, in addition to just dealing with the underlying condition. That means physical therapy, exercise programs. That's good probably for anybody in a survivorship program anyway, to get back to functional status. Dietary nutrition, somebody who's diabetic, who has colitis, who has other things, you're probably going to want to make sure that they're eating properly, that they're able to maintain good nutrition moving forward. It's also a good reset. A lot of times, obesity is a risk factor for any kind of cancer. And sometimes having this cancer diagnosis, if you survive it, you kind of get a second chance to maybe do things properly from a nutritional standpoint moving forward. And then things like behavioral, emotional support. I mean, a lot of times when you're going through therapy, you can't think of that stuff. And then when you're done, all of the feelings come in. Just because then all of a sudden you have a bit of a break, a time to breathe, and you get to focus existentially on stuff. And oftentimes, from a physical doctor, medical oncology standpoint, we maybe don't pay attention to that as much. But it's equally as important to recognize that you just went through a trauma, however long it was. If it was 6 months of chemoradiation or 2 years worth of immunotherapy, and any trauma has a risk of having PTSD. And a lot of times it has those kinds of connotations. Less so if you have a better system surrounding it, an emotional system, but not everybody has that. And you have to make sure that at least screen for that as well. And a lot of times these people are young enough and then they're doing well enough, they want to go back to work. And what does that mean in the context of their ongoing ongoing treatment. So what do we learn? Just kind of review what we discussed. Number one, overall survival in cancer is trending upwards, has been for the last 30 years, pretty significantly so. Checkpoint inhibitor use has increased significantly in the past decade, as you guys saw, from 91 prescriptions to over 450 prescriptions. Chronic toxicities are being recognized more, just because there's more patients who are alive with them, and also more patients who are exposed to them long term. And more patients are living longer with these chronic checkpoint inhibitor toxicities. So what that means for us is, let's just make sure that our survivor follow-up activities should incorporate evaluation for these checkpoint inhibitor toxicities as well. All right, thank you.
Right, round of applause. So he did leave us 5 minutes for questions. That probably gives us about 2 or 3 questions.
Yes, ma'am.
You, right there.
Thank you so much for all that information. What I'm trying to think of is, do the toxicities, severity as well as duration, depend on how long you've had the medication? I think that would be true, but just for my own, is that statistically correct?
Sure. The short answer is probably yes, not always, but probably yes. The longer you're on it, the more likely, higher percentage of a chance that you will get some sort of toxicity. The severity, probably not as much. Definitely the severity can happen early or late, but the incidence, the likelihood that you would get some sort of toxicity, definitely, the longer you're on it. Absolutely. The longer you're on it, the more likely it's going to last for longer. Especially since the longer you're on it, the more likely you are to get things like the pneumonitis and the endocrine toxicities and neuropathy. And those are the ones that really tend to have a more long-lasting effect. Even after you're, a year after you're done with your last dose of immunotherapy, it can definitely still linger. Yeah.
I'm noticing that the immune therapies are just for the T cell, not the B cell.
Yeah, for these particular ones, yes, but you can imagine the B cells are being studied also. A lot of times there are things like the MABs, the monoclonal antibodies, things like rituximab, obinutuzumab, trastuzumab. Those are more potentially B cell or general immune therapies. These particular ones are targeted at the PD-1, PD-L1, which exists mostly at the T cell level.
So they're doing research with B cell also to find.
Yes, yeah. Research, and also actually there's some therapies that are aimed at those also. Like for instance, for lymphoma, one of the big things that have happened in the last 25 years is the creation of rituximab, a monoclonal antibody, MAB, and that's against the CD20, protein, which exists on a B cell. So those are occurring as well. Have a different mechanism of action from these checkpoint inhibitors.
Thank you.
Dr. Rosales, is this age specific? This type of treatment, would it be effective for children?
No, it actually is not. It's a cancer, or it's specific to that protein. Like it's not even as important what kind of cancer you have. The question was, is this specific to age? It's actually specific to the, well, I guess we'll call it the molecular signature of the protein. So it's not across the board true, but the thing that we check is this thing called the PD-L1 receptor, or PD-1 or PD-L1. The higher the percentage of PD-1 or PD-L1 is present in the tumor, the more likely that you have a good response to immunotherapy. So the way they have it now is there's less than 1%, 1 to 49%, or greater than 50%. Greater than 50% is a high PD-L1. Oftentimes we treat those patients just with immunotherapy, not even chemo, and they have a good likelihood of response. If you're less than 1%, you still treat them, but a lot of times you'll combine it with chemotherapy, and the likelihood of the response from the immunotherapy lingering past that is less. So less likely of a prolonged response. So it depends not so much on the age of the patient or the type of cancer, but on how the PD-1, PD-L1 molecular testing looks like.
I was just curious about what type of chest x-ray you might recommend. I'm currently on Keytruda and Cytoxan, and I developed what they thought was pneumonia maybe a month and a half ago. They put me on steroids. It cleared up for a couple days. Then it seemed to go into bronchitis, and we have lots of wheezing. Now they're talking about asthma. I've never had any of those things before. My oncologist said that it could be a symptom of the Keytruda.
Yeah.
So I'm just wondering, what your recommendations are for maybe a chest X-ray or what that would look
No,
like.
great question. So the way that I would normally follow that, we'll do a CT scan rather than a
scan.
chest X-ray, only because you see things more. It's more of a sensitive test. You don't need a PET scan or anything like that. At least a PET scan seems like it's a bit overkill. It'll give you more bad information than good information. But a CT of the chest with contrast will give you a good overview. If there's a question, if it lingers and you're not sure if it's responding or not, the definitive test, if you can get it, is a bronchoscopy with a biopsy. Being seen by a pulmonologist, they can do a bronch, get a sample to see are there a lot of inflammatory cells there. Those are probably the things that you can check. And plus, you can check is it other things. Maybe you have a fungal infection that's causing inflammation. Maybe you have atypical bacteria. Then you'd be able to figure that out from a bronchoscopy as well. But as far as imaging goes, the standard at this point is a CT chest with contrast.
All right, guys, one more question here.
Yeah, I've got cancer. They already cut a piece out of my face, but I also got I don't even know what it's called, but I get these little blisters, and if one pops, it spreads throughout my whole skin. I got to put clindamycin phosphate on it, or it gets real bad. Do you even know what it's called?
Short answer, no, I don't. However, if it keeps happening like that, if it's responding to clindamycin, it sounds more of an infectious thing.
It's been going on for 2 years.
Have you ever had it biopsied by a dermatologist?
I have, but they said it's an infection that can't be cured.
There you go. Yeah, so normally, especially if it responds to clindamycin, clindamycin is more of an antibiotic and doesn't really have a whole lot of anti-cancer properties. The fact that it responds to clindamycin tells me it's more likely to be infectious. And a lot of times, unfortunately, these bacteria, our skin has bacteria all the time. We can't really sterilize the skin without destroying it. I bet you what it is, for whatever reason, the immune system is just allowing that bacteria to come back. As long as it keeps responding to the clindamycin, then that's okay. But at the same time, you got to make sure to keep keep a close eye on it so it doesn't spread more than necessary. Are you on active treatment right now? Oh. Well, what I would check is just to see if your immune system is off. Because a lot of times, again, there's bacteria in our skin all the time. Oftentimes, they don't grow there. The fact that it keeps growing back kind of makes me think maybe you have some sort of immune difficulty or deficiency. If it hasn't been checked, I would check that to see if there's anything we can do to prop up your immune system to prevent that from coming back. That would be where I would go. All right. Happy to. And on that note.
Round of applause for Dr. Joe Rosales, everybody.
That's right, Dr. Joseph Rosales. I'm over at St. Joe's, just down the street. Happy to see everybody. Bye-bye. Thank you.
So, our next speaker is Peggy Sturdivant. Which do you prefer? All right. She's been a facilitator with Seattle's Cancer Lifeline for nearly 2 decades. She is the creator and leader of Writing for the Moment. It's a weekly session focused on informal expression. She's a dedicated member of the Cancer Lifeline Advisory Group. She also holds a seat on the Association of King County Historical Organizations Board and established the Ballard Writers Collective. Peggy collaborates with writers of all generations, from 10 to 95, through moving words writing and individual mentorship, empowering every participant to discover the significance of their personal narrative and voice. Can we give a round of applause for our next speaker, Miss Peggy Sturdivant? She'll say it.
I say Sturdivant, and my sister-in-law says Sturdivant. I don't know. Thanks for, recognizing someone who's not tall. One time I had to get the attention of an entire group, thank you, during cocktail hour. And so that was tricky. Another time I had to enlist the tallest guy in the room to come stand up until everybody was like, why is there a tall guy standing in front of the room? And then I was able to start. I don't like to think of myself as short. I'm just not that tall. So I was invited here in December, and I pictured a little room with 7 or 8 people. So this is thrilling. As a writer, to see an audience is like, it's my dream come true. So thank you for all making the time for yourselves today. And if it doesn't sound, well, too out there, it's wonderful to see so many men because most of the classes, yeah, thank you. Yeah. I do have, men in many of my writing groups and writing classes, but it is predominantly women. And I would love to have more men because I think it's really valuable, all the time. So a little bit, I want to start by showing a picture, a little bit about what he covered with me as well. But I just want to show you my most valuable possession in the world. That is a quilt that was given to me at the start of the pandemic. And it was being secretly made by a number of the people who've been writing with me for a while. They had asked other members of the writing group what they wanted their square to be. And they said various things, like the person who I share a half birthday said, I want it to be the 6 of hearts because we're twins. Another woman said, I want it to be like when you plant a bean seed because it grows so fast and all the leaves branch out. And then on that, she had like bonding and community and self. And it was a surprise that was meant to be a bigger presentation, but proved to be just in my backyard. And every single day, I look at every one of those squares and just treasure the time that I have. This is one of my favorites. I don't think it's actually even meant to be me, but I love it. It's in the center, and the little pen is writing for the moment, which is what I call the writing group that I mostly do. If I'd known you were going to have tables and paper, I would have made you just start writing today, but that can be an option. So, my little actual notes out here. So how did this quilt come from writing, and how did writing lead to this quilt? It all has to do with the resilience that we have in ourselves that's in words that sometimes need to be let out so that they become more powerful. So I'll go back a little bit. 2 weeks to the day after my husband, when I had a 2-year-old, coincidentally, had just learned that his will was invalid, I had to have a root canal. And the weight of the lead apron triggered a sense that I could no longer move my limbs, which made me feel like how it must have felt in my husband's, last days. And add the laughing gas, and I was definitely on the verge of a panic attack. And then with the smell of flesh still, with root canals, the work stopped, and this insensitive periodontist announced that he would finish on a later date. And so I managed to find a single occupancy bathroom in the building and lock the door. And then sobbing, humiliated that we had screwed up the will, I was in human resources back then, I vowed that I would never tell anyone about our stupidity. Then I found enough paper in my purse and a pen, and I started writing out all my emotions: grief, betrayal, confusion, you name it, I wrote it. But an hour later, I was able to unlock the door and emerge. Within 2 hours, I'd confided the mess to my best friend by telephone. And by the time I picked up my daughter from a friend's house, I was able to share the situation, already shaping it into a story. The story of distracted, well-meaning people who had made a mistake that would take years to right, but that I would survive. It was 1993, and the term resilience wasn't as popular. But if I had not had paper and pen in my bag, well, I would have had to write on toilet paper. But until I wrote myself out of recrimination, anger, guilt, despair, and back to the strength that I had found as a partner to someone for 8 years with a cancer diagnosis, I wouldn't have been able to face the world again. So finding resilience through writing isn't always so dramatic, but once you find its power, it can sometimes feel like a superpower. And you all have that. And you certainly don't need to be a writer. I'm putting it in quotes. Just about every week, somebody new joins my writing group, and almost the first thing they always say is, "But I'm not a writer." I'm like, it doesn't matter if you're like a writer, like you put like quotes around poet or something. We all use words. We all have our thoughts. Whether we're planning to do anything with them or not, share them with anything for ourselves, they're our greatest gift to allow ourselves the time to think. So I don't think I ever looked at what was written, when I was sitting on the tile bathroom floor. I wouldn't want to read it, but it got me out of there. So encouraging others to write on whatever is at hand. It could be, phone now, napkin. I've known people who had to grab Band-Aids, receipts. It's helped get other people out of the room. It could be the room where you wait while they're checking for clean margins, or they call in the radiologist to take a quick peek. I know one woman who had been stripped of any writing utensils and was terrified in a sterile room. And so she closed her eyes to picture first as though she was actually writing sort of a list of her terrors, and then to calm herself. And this always just kind of makes me emotional to think about it. She calmed herself in this room where they'd left her alone, picturing the faces of us as she knew us, had never met us in person, but on Zoom, the people who listened to her writing every week. And then once she got our faces in her mind and she felt strong and emboldened again, she mentally drafted the letter she would later write about how to humanely treat a scared human being. The lesson being, though, try to sneak in paper. So I was a journal keeper. So I came to the need to write out worries really early. Sometimes I wrote joys too, but when you're a preteen, it's mostly your worries. So I've always been a worrier. I was oblivious, though, to the full potential and the lifelong need that we all have to express ourselves and to realize the power of what it can do. So in 1997, so it was still way back, I finally signed up for a class that I'd been eyeing for years, but I thought it sounded too kind of woo-woo. It's called Self-Discovery for Women Through Creative Writing. And although I had always used that journal to talk myself down, the self-discovery term made me kind of queasy. By then I was 37 years old. My daughter was now 6, and it had been 4 years since my husband had died of Hodgkin's disease. I went to the class, which was held in a shabby middle school classroom, and realized within probably an hour that I needed those hours each week, as did everyone else there, needed an opportunity to sit with paper or keyboard to capture thoughts that were swirling through all of our days and nights. Lists, worries, good days, bad days, the moments of everyday life in every circumstance. And that can be, as a caregiver, as well, of course, as a person who's going through treatment. I remember one of the things that was hard was that during my husband's illness, I would be at a different place, very, very different place mentally than he was. And to share my thoughts with him, or him to share his thoughts with me right then, wasn't something that we could do. So thank goodness I always had the journal. So for as long as that wonderful writing group class existed, I wrote every week. And my father used to ask, why I had to keep taking the class. He didn't know the word was misleading. It was really more like a beautiful, supportive therapy. I mean, I'm still in touch with people. I'll see somebody at Trader Joe's and we'll recognize that we'd shared those moments years ago. There's no graduating from the need or the ability to use writing as a tool for survivorship. So never. If you have something happen so that your writing hand or your keyboard hand isn't good, you can always scribe these days to your computer, your phone, a trusted friend who swears they won't read it. Getting the words out, so important. So here's the truth. In allowing ourselves the time to write, to process those thoughts that are spiraling through our brain at all times, we can learn something about ourselves every single day. We recognize our innate strength, and we have it for the days when we need a reminder. The amazing poet Andrea Gibson wrote a poem that could exist just for its title. In the chemo room, I wear mittens made of ice so I don't lose my fingernails, but I took a risk today to write this down. That's the title. And just sit with that in a moment. In the chemo room, I wear mittens made of ice so I don't lose my fingernails, but I took a risk today to write this down. So, everyday life doesn't stop for cancer. It just adds to the balancing act in which we often still have to take care of others and are juggling a diagnosis, treatments, terror, with daycare, elder care, responding to friends who don't feel comfortable around you, and family members who are experiencing their own feelings. One night I called Cancer Lifeline's actual lifeline because I felt so alone with the others asleep upstairs. And later my sister seemed to chide me for calling a stranger. Like, you had to call a stranger? Why didn't you call me? It was like, what I needed was a stranger. Someone to just listen without judgment and not try and say, yo, but you're so strong, you're so brave. I just needed a listener. One of the things that came up and comes up from time to time with some of my different writing groups is they say all the wrong things. So in groups where we voluntarily share what we've written, one woman whose partner had a bone marrow transplant, said these all too common words regarding friends and family. They don't always say all the wrong things, but in order for it to be safe to share, sometimes the safest listener is ourselves. And then we can help others learn how to listen and know what it helps to hear. We know best what we are experiencing. It's our truth. And being told, oh, don't worry about that yet, or, well, you've all heard various things. I see lots of nods, sorry. It's our truth. And being told, oh, don't worry about that yet, it doesn't help. What helps is listening to ourselves, and doing it with pen or pencil in hand lightens the load. You can always, if something's painful, you can always kind of rip it up after. You can throw it away. You can hide it. See, that's the great thing. You've given away part of that. Share the joy. If it's a good thing, stick it up on your mirror so you can read it every day. But some things you may want to just toss or be sacramental about it. So when I first started attending that wonderful writing class, I was a bit alarmed when there was another woman, and she was writing very emotionally, and another widow, about her husband's unexpected loss 17 years earlier. And I thought, will this be me? I mean, 17 years, this is still what I'm going to be doing every week? And what I realized was that when, and in her case, it was a lost fighter pilot, sort of thing. Very sudden, you come home with the kids in the car, and there's military people, pulling into your driveway in uniform. And she put all her grief like in a closet because she had young children. She had to start working. She had to get through. And so when she found this writing class, it's because her kids had gone to college and she didn't have to hide and pretend anymore. And she had never processed her loss. And so you'll find, unfortunately, that things will always trigger. There's always going to be memories hiding in the closet. But seeing them and recognizing them again and just knowing that you've survived it before always helps. And you start to kind of, I don't know, they become softer. But as James was sharing that he'd heard too, about some of the writing now, it doesn't go anywhere. If you just stuff it down, it's just waiting. It might even be growing in there. So there's always going to be some painful parts and some wonderful parts. So get them so that you have more control of them. So I think of that woman, and I think, what if she had even 10 or 20 minutes a day that she could journal or make a list of words, just along with her daily to-do list, that just listed what she was feeling. And the words that we put down, especially if we don't think about, I'm going to share this later, they can come from a place that we don't access by speaking or merely thinking. There are brainstorm aspects. The brains are very complicated things. I've worked now with experts in the field of neuroplasticity and neural pathways, and they can explain how thoughts in the frontal lobe are different from other parts of the brain. They can explain it, but I can guide it and get people through, brainstorming, not thinking too much when you write. You can call it morning pages or the artist's way. These are all methods of accessing thoughts that are closer to our emotions and our dreams. And they would all like to have a word. They want their place. So 2004, I left my work to become a writer at large. And I've had the opportunity to go from the participant of a writing class at Cancer Lifeline to facilitator. And as mentioned, for nearly 20 years, I've been leading what I call writing for the moment, which is literally what it is. It's like you take that time, you log in these days. I've sent a poetry prompt ahead of time. I say, okay, we're going to write for about, 12 minutes. And what people share after writing for just 12 minutes is extraordinary. Sometimes it seems to come together in a way that always reminds me of the quilt. It's as though we made something that was I wish I could hang on the wall that day. It's so beautiful the way it links together, just through people sharing honestly. So speaking as the facilitator and a participant, because I write too, they're the most rewarding hours of my week. And I now have people who are joining from Alaska, Oregon, one person on vacation, New Zealand, Mexico, someone who moved to Albania. Sometimes this woman I know lives about 6 blocks away. But it's made it so that we don't have to drive. It's better with people who are immunity issues or immunosuppressed. And so it's actually been very liberating, and it feels just as intense to be together online. I've been very lucky that way. So as I said, what's important is letting those thoughts that may not have even surfaced leave your mind, come from your hands, leave the monkey mind behind. Because once they're exposed to air, they have a different power. An unspoken fear may lose its power once it's expressed. And all of you are writers, by the way. You were born with your unique outlook on the world and way of expressing things. And we don't always think of ourselves as writers. But each of you was born with your own genius. You wouldn't describe even a food the same way. So letting your own pen or fingers go can reveal parts that are stronger than you realize. So, why write? Let's see. Why? Okay. This is a quote by a woman who was also a hospice worker. And I keep a handwritten copy of this in my office because it really speaks to so much of the need. As she said, this writing, this time, and this writing is for me, not for anybody else. You know, how it quiets her minds. And especially as someone who was in a situation of having to support others in hospice, she did not want to share her own cancer journey with them. And so this is always, I love that, quieting my mind by writing out the thoughts tumbling forth or not tumbling, you know, just being. So I can speak to the 10 minutes and how it helps me, but there are so many examples that I get to see, you know, every week. I have a woman named Marty who I think has been writing with me for about 15 years. She's a member of numerous other support groups, but she actually drove from a mammogram straight to Cancer Lifeline to find out what their programs were. She just knew she was going to be starting to participate. Another woman, Barbara, recently shared the story of her husband being part of a caregiver study, and he brought home information about Cancer Lifeline and said, oh, they have a writing class. And she had just finished treatment, and she claims she just like dropped the catalog right in the recycle and said, I'm done with cancer. And then a year later, she was missing writing, and she wanted something that was during the day, close by, and not focused on cancer, such as a support group. So she said, you know, I guess I'll try that writing class. And as she says now, and guess who wrote about cancer for an entire year? Now, she doesn't write as much about cancer now, but she still needs to write. And as with many others, has become a very close friend. I make a lot of friends. So when someone is in the thick of cancer, there's usually a team. And when the course of treatment is over, it can seem like an abandonment. Like, where's the 24-hour call team? Where's the meal train? You know, who's checking in? So a lot of people that start finding time in their lives and a little more energy to write come after the treatment and after the recovery is really starting, because there's so much to process then. It just so happens for what I do most commonly is I send 2 poems ahead of time, and I always say I can't explain the poems. Usually there's just a phrase. I liken them, but I call them palate cleansers, because it's just a way to say, okay, I'm not, you know, waiting on hold anymore, or I'm not dealing with that insurance. I'm not doing the next thing on my to-do list. And just a line or a phrase can sometimes lead someone to sort of open a window. And they always say, I didn't expect to go there today. I had no idea that this is what I'd write about. And that's what it should be. And sometimes people need to just write a list. And another favorite of my prompts is a letter that will never be sent. That's the one that could get you in trouble if you send it. But it could be to the phlebotomist, you know, who didn't listen when you told them exactly where to, you know, find your vein. But maybe it's to the oncologist who actually did listen. Sometimes these letters do get sent. So when my then boyfriend, later husband, was diagnosed, we naively thought, and remember it was the 90s, that he would be cured or die. But we didn't realize that for 8 years, he would have a chronic disease, that we'd be living with cancer, or in my case, give birth the day that he had a bone marrow biopsy. And I kept a journal the whole time. I can't bring myself to look at it now, but it helped me sort out everyday life. the terrors, the joys, so I could sleep at night and laugh relatively soon about having to flush his portacath while a 2-year-old jumped on the bed. And that daughter now has her own almost 2-year-old. So every week I have the privilege now of writing with people who are claimed to be not writers. So a couple ways to give you some tips. You may say, oh, this sounds good, but how do I actually get started? I always believe in starting with a list. If you don't have something that's driving you right away, and you can just like take a piece of paper, throw down some columns. You might have to get that like immediate to-do list out of the way, but then you could move on to other things. Quite often when I encourage people to do foods, boy, do we have a lot of fun. Oh, foods just leads to stories and recipes, everything. So then what you can do is if something kind of pulls you even more, you can say, ooh, looks like this is what I want to write about today. So also, if you're scared of like deciding, oh, I want to write, set a timer. So you can just start with 3 minutes for a list, and maybe I'm only going to write for 5 minutes or 10 minutes, and just try and keep your pen or pencil moving, and you'll be fine. So another thing I recommend is that you give yourself another kind of list, which is a list of your accomplishments. I've noticed years ago that when we make lists, even if we've had something that we've been meaning to do for years, when we do it, we cross it out. I'm like, hello. So I decided to start making a list, and I've been doing it for about 10 years, by year, of what I've accomplished. And I will be putting this down today, by the way. So I find it's really helpful. If you were meaning to like have those people over to dinner, that counts. Everything counts. You know, you made that phone call you weren't meaning to take. You did something actually really quite big. You know, you pulled off a fundraising or a raffle or a cancer survivorship conference. You got to write that down, because we tend to cross out what we've done. If you write for 10 minutes one day, you should write that down. Absolutely. So, other ideas. The list can lead to, like, say that you just want to do some what I call 30-second blasts. You can't get out of your craw what, like, the insensitive receptionist said. You know, write it down. You can move on to, like, more timed writes. I love the letter never sent. I like to take things like a recipe, like you take a recipe, something maybe you know by heart, and you make it like, put in a different word, like ranch dressing for regret. I just made that one up, you know. So you could put in, you know, love, fear, worry, joy. Go through you still got little handwritten recipe files? Go for them, you know. Share those, and then just kind of tweak it a little. Poems, like, you know, if you see something, you may not even like poetry, but you find a line and like that. Repeated phrase. I love repeated phrase. So I often give this to my middle school students. So you can kind of start, and you can do this like this, the ellipsis. If only I had known, ... If you want to know me, you know, ... I think I still have it in my heart someday. And just a few weeks ago, I had a poem that I took that was called The Book I'm Writing. And boy, everybody just went nuts with that one. You know, it's just like the book I'm writing is about, you know, a child who wasn't listened to, but who became a parent. You never know. The book I'm writing today is going to be entirely different. So, just remember that you're not writing or worrying about an audience. Many people do better finding like a writing partner, somebody that they feel safe with, to say we're both going to write. You don't have to share it, but like say, you can say, hey, did you do that 10 minutes today? And they say, yeah, I did that 10 minutes today. Many people like to use Caring Bridge, which is a great way. There's in-person writing through different groups, senior centers, online classes. I know that Cancer Lifeline is out here today. So, they have a catalog list. This is something that was shared by one of my newer students very recently. And as she wrote, the best results are when I crank something out that I didn't know was inside of me and feel like I just shed 10 pounds. It's a marvelous feeling. The itch gets scratched. And I'm not here to give you statistics on outcomes or whether they're influenced by writing, but I can tell you that I hear relief in voices, in the ability to share fears and joys without judgment, or someone telling you that you shouldn't feel that way. You feel what you feel. And the act of capturing the words on a scrap of paper or, a composition notebook, an app on your phone, it's all to the better. I mean, just think of something you can do for yourself. It's like 2-3 minutes a day. Unbelievably good. Over the course of years, Cancer Lifeline has asked writers from all the different groups if they want to share their writing with the Northwest Collage Society, and it is always amazing. This is one of our newer writers, Lauren, on the left, and her artist. And so we'll send the writing, and the artist chooses it, and then when we have this opening, they'll say, "Where's my writer?" And believe me, for us closet writers, that is thrilling to be able to see. And then this is a 17-year-old in one of my writing groups. He had lived with, in his teen years, his dad had cancer that whole time. And when I asked him if he wanted to do a letter never sent, he said, "Nah, I think I've worked it all out." And then I said, when shall I get a few more things out of your head? And that led him to suddenly be sitting on my front steps for 15 minutes, 5 pages, and he couldn't stop. So I like to think that it helped him that day. Cancer Lifeline is here and out in the lobby, and I've been thrilled to be part of, their facilitation for years. And other than that, I just say, throw yourself a lifeline and do some writing. Thanks. Questions? Okay, if you have any questions, they have, so they can hear it on the recording. Either that, I did such a good job, you have no questions. Oh, someone way in the back there. There.
This may be the first time you've been asked this question. I have been afraid to write at my age because I want to be able to write about how I'm feeling, but I don't want when I'm gone, I don't want my family to read it. And so I was just thinking as you were talking, I think it's possible to set up a file on my computer that's password protected and nobody can read it, and I had not thought of doing it that way. But is that?
Oh, believe me, it is a big topic of conversation with all the people who have been lifetime journalers about when and how they will be destroyed. So, especially if you do prefer to write online, absolutely. I'm sure there are ways now, unfortunately, you could probably Google how to set up a file to destruct at such and such in time. But no, you should never have to worry about somebody reading it, because our thoughts can change from day to day, and sometimes those are things that we know might hurt someone to read them, but they were written in the heat of the moment. So please don't be afraid. I hope you'll start writing right away, because it is so helpful at any age. Thank you.
Quick question for you. So obviously you're developing a ton of different prompts, weekly prompts, want to keep them fresh with your group. What do you draw to for inspiration to help you develop the prompts for the group?
Well, I search for poems every week. And so I also created a little free public poetry library. And so people bring their poetry books to me. And so every week, I just find poems that maybe have one line that speaks to me. I'm totally selfish about that. And then I put it out there and I just see where they go with it. And the only thing I learned is don't ever put a dead dog or a dead cat in a poem. That does not go well with any group. But other than that, I just love exploring poems. So I go to Poem a Day, Poetry Foundation. Sometimes I will just put in a name, like I might put in the name Melanie, and I will Google to see if there are any poets named Melanie. It's really fun. It's sort of like a little game I play with myself. And I discover so many poets and writers, and then I just get to see what they do with it in 12 to 13 minutes. It's incredible. Thank you.
I find that it's okay for me to deal with my dead cats because I find when I'm getting my blood pressure taken, I take a stroll through time with my dead cats, back to my childhood cat, to the next cat, the next cat, the next cat, and then to the cat that I have now. So I never write it down, and that's a secret that I go through when I do my blood pressure. And the other thing is I find people are listening to these audio books. I don't. And they say, what are you doing all the time inside your brain? And I say, oh, there's so much stuff just jumping around up there. So, but I don't write things down. I just jump them around. Thank you.
One of the people who I first have had in the class, who actually got me the writing gig, she said, I write a poem every day. And I was like, oh, wow. A lot of people do that now. But it turns out she made a poem about every day in her head. She still does, something of beauty. So.
It's very difficult to get it published. And how do I get people to read my stuff?
Couldn't quite hear that.
I said I write lots of poems and I want people to read them, but getting them published is a whole lot of work and not very successful. How do I get people to read what I write?
Well, more and more people are starting something like on Substack and online, or if you're still willing to do Facebook. People who I know who just don't want to try and send them out and get rejected do find ways to share with other people, and those get very widely shared because they speak to the people. So if you're in any support groups or things, just go ahead and find a way to start sharing them, even if you're making copies, because you never know how affected someone will be by what you wrote. We should. So many people apologize for their writing before they read it. They say, "Oh, this didn't go anywhere. This isn't very good." And this is like, well, don't. It kind of demeans us who are listening. We happen to think it's like beautiful and wonderful, and so don't rub it in the dirt. So we should never know how something is going to speak to someone else, and it is tricky to be able to find to share, but. I hope that you'll be able to find ways.
How do you find a support group?
Often through, what most interests, through your interests. So, happy to talk to you about it. All right, probably maybe one more. I know we have a hard stop because you guys have lunch. And I think there's still cookies back there.
Here you are, my love.
To piggyback on the first question, if someone had still a lot of old school paper journaling, Is there a more meaningful way to dispose of that in someone's lifetime other than a shredder that you can perhaps talk to if you have thoughts?
I have a lot of thoughts. You know, one time I went to a writing retreat and they used one of those little forklifts to carry my box of journals to my little cabin, and I didn't even open it. Yeah. So it's a carrying thing. But during the pandemic, I started going through my old journals, and there's a woman who did something I thought was amazing. She started taking like her journals, going through them, and kind of culling them. And that's what I've been doing lately. I've been like culling my journals and finding what's just blah, 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 blah. And what actually stands out, sometimes, you know, ripping it out, sometimes making it into a collage, putting it into an online thing, and then letting go of the hard copy. And then this woman made this beautiful 100-line poem out of like one of her journals. And I was like, and I've had her come back and do a writing craft talk about that, because how brilliant is it to take and cull some of that angst and find the beauty in it and then turn it into another thing. And then you can perhaps let go of the hard copies. So thank you all so much.
We have one more speaker that we're going to give the floor here for 45 minutes. It's Mackenzie Jackson. She's a, oh yeah, woo! Somebody knows her. She's a physical therapist and a certified lymphedema therapist. She earned her doctorate of physical therapy from the University of Florida and received specialized certification from the Norton School of Lymphatic Therapy. Mackenzie focuses her clinical work on oncologic and orthopedic care, where she is dedicated to enhancing function and quality of life for individuals across the survivorship spectrum. Outside of her professional practice, she enjoys the scenic Pacific Northwest, because how can you not, with her family and her friends. So, round of applause for Mackenzie Jackson.
Thank you. So, like I said, welcome everyone. I hope everyone got some good food to eat. I know I did, and I'll try to keep it lively for the next 30 to 45 minutes, because I know after lunch we all kind of get a little bit tired. But today I'm going to talk to you more about cancer-related lymphedema. So as he mentioned, my name is Mackenzie Jackson. I am a physical therapist based out of Puyallup and a certified lymphedema therapist. As he said, I did get my doctorate of physical therapy from the University of Florida, but I am born and raised in Kirkland, Washington, so I've kind of traveled all over. I was chasing the sunshine for quite a bit, but came back and realized Washington is the place to be. And then I also received my training from the Norton School for lymphedema through a very long kind of course process that was an add-on to my physical therapy degree. I'm really passionate about assisting patients going through their cancer journey and beyond, really trying to help optimize function and not just survive cancer, but really thrive afterwards. And so today, kind of with talking about cancer-related lymphedema, I'm really going to walk through what is lymphedema, the risk factors associated with cancer-related lymphedema, talk to you about strategies to reduce your risk of developing lymphedema, and then also when to seek support from a cancer rehab therapist or specifically a lymphedema specialist. So we recognize that cancer is a journey and that not everyone's path is the same. Kind of everyone starts at a different place, whether it's your age, your beliefs, your support system, of your family and friends, your general health and well-being. All these factors, among others, really contribute to where you start at the beginning. We also know that your destination may be different. Where are you going? Is your destination kind of to finish treatment and put cancer behind you, or is it to live with a chronic condition and manage those side effects to live a normal, independent life as possible? Your destination is really determined by the goals you set with you and your cancer care team. And then once you get diagnosed, kind of your path may take you through all these different treatment choices. So you may undergo surgery, chemotherapy, targeted therapy, and radiation are all customized by your cancer care team to help meet your needs and get you to the destination kind of determined. And with all this specialized treatment, each person's side effects and intensity of these side effects are going to vary as well. The tolerance to treatment will really be impacted by your overall well-being and kind of where you start at diagnosis. A cancer care therapist and kind of the teams that I work with really want to help keep your motor running smoothly and kind of help you through the experience and manage those side effects to really get you to your destination. Now, before we really talk about lymphedema, which is a dysfunction of the lymphatic system, we really need to first understand a little bit more about the lymphatic system in general. So we're all born with a lymphatic system. It's really vital to our immune system, and it allows us to fight infections by ridding our bodies of toxins and promotes a good fluid balance within our cells and tissues. But really, how does it do it? Well, if you think about there's two main circulatory systems in the human body. So one that really carries the blood throughout your body in that circular fashion, so from the heart, the arteries, capillaries, veins, and back into the heart. But then the lymphatic system is another circulatory system that really carries that protein-rich, what we call lymphatic fluid, which is responsible for returning the fluid out of your tissues and back into your heart. And then once that fluid returns to the heart, it then moves to the kidneys to get filtered and removed as urine. So the lymphatic system is throughout the body, both on the surface and deep within our tissues, our spine, and our organs. The surface, or the superficial system, is kind of divided into different regions, and these regions have division lines, kind of known as watersheds, that kind of go through kind of your midline down to your abdomen at the level of your belly button, and it kind of helps divide the superficial system a little bit into regions. So as your body moves fluid through this top layer system of the lymphatic system, it doesn't usually cross these kind of boundary lines, and that can kind of dictate what area of the body a group of lymph nodes help filter the fluid and the waste and the toxins and all that unneeded material. Which is why when lymph nodes are removed, we kind of know which part of the body to kind of monitor for changes in the system not working as effectively. For example, let's say someone has breast cancer and they have lymph nodes removed from their right armpit. We're going to really look at that right arm and the chest, the back, for any changes of swelling, because it's not always just the arm. It can be that whole body region that's affected by those lymph nodes filtering that fluid. So what is cancer-related lymphedema? So it's that accumulation of fluid and fibroadipose tissue due to the destruction of lymphatic flow from cancer and its treatment. So I kind of want to break that down a little bit and explain a little bit more of really what that is. So accumulation, or that buildup of more fluid in an area that's typically there. That lymphatic fluid is a lot thicker than water, and the toxins and waste and unneeded material kind of clump together and over time create fibroadipose tissue. So fibro as in fibers, or that thick network of tissue, and then the adipose meaning fat, so just taking up kind of more space in that fluid space or that tissue space that doesn't have very much space to begin with. And this kind of makes it more difficult for the lymphatic fluid to move through the vessels, through the circulation and back into the heart to then get excreted as urine. So when someone undergoes cancer treatment, they have a change in their lymphatic system through surgery or radiation, making it more difficult for that body to move the lymphatic fluid. And these factors, along with obesity, injury, and infection, can all lead to the destruction or reduced movement of the lymphatic fluid by way of impeding those lymph nodes or the lymphatic vessels. And then that can kind of create a buildup in the tissue, as you can kind of see in this person's arm and this person's leg. So it's really important to know, though, that this doesn't happen overnight. Small changes in the lymphatic system kind of build with time. And it's not going to, one day you have it, and one day you don't have it, and then one day you do. It's that slow kind of progress. So if you're seeing a very sudden change in swelling, it's really important to kind of contact your doctor, get that checked out, because it's not likely lymphedema, because again, it's going to be a gradual change, and you're not going to one day just have a swollen arm or leg or torso. And it's also really important to know that not all swelling equals lymphedema. So you can have lymphedema or edema or swelling related to venous system problems, so your veins not pumping back up to the heart well enough, water retention, arthritis, organ problems, so dysfunction with the kidney and heart are typical causes of swelling, medication reactions, lipedema, or an injury like an ankle sprain. All these are going to cause swelling, but that swelling is not lymphedema. We also think when people see We also think of, typically lymphedema, we think of breast cancer, but lymphedema can really occur with any diagnosis in which the lymphatic system is being impacted. So in additional cancers that are more common to see lymphedema as a side effect include melanoma, bladder, sarcoma, uterine, head and neck, cervical, vulvar, and prostate cancers, all because they have some commonalities in their treatment that makes people at risk for developing lymphedema. And of course, these are known as risk factors. So talking first more about the risk factors of lymphedema. So the extent of local surgery or lymph nodes being removed is definitely a factor. So typically the more lymph nodes you have removed or damaged by surgery or radiation is going to increase your risk. Typical guidelines I tell my patients is typically 4 or more lymph nodes puts you at a higher risk of developing lymphedema. Also, radiation to the lymph nodes or the surrounding area is going to impede the ability of those lymph nodes to filter toxins, also the ability of the lymphatic system to move that lymphatic fluid. And then also a higher body weight and sedentary lifestyle. So evidence has shown that a BMI of over 25 can increase your risk of developing lymphedema. And then the sedentary lifestyle, just not being very active, exercise has really been seen to be a really positive effect to decrease your risk of lymphedema and cancers. And then the last one is infection and injury is another common one. So if you have an infection to kind of either a systemic infection or infection to that area, that can increase your risk, or a previous injury. So for example, when I'm going through an evaluation with someone, and I kind of am looking through all these risk factors as I'm looking at their history, taking kind of seeing where their treatment plan is taking them, what they've already gone through. I kind of look at each one of these. So knowing that they're going to have lymph nodes removed, I kind of keep that in the back of my mind. If they're going to have radiation and the extent of radiation, I kind of think about that. Kind of their current activity level, I take into consideration if there's any likelihood for infection or previous injury. And I tell people, like, let's say again, I work with a lot of breast cancer, so I'll kind of refer to that a little bit more. But if someone has breast cancer and they have a previous shoulder surgery, kind of that right there can increase their risk. So it's important to know that not one risk factor is going to immediately say you're going to have lymphedema or not. They can kind of compound on top of each other, and not everyone will have all of these risk factors. So kind of what might you first notice if you're starting to develop signs of lymphedema? So you might notice that your clothes aren't fitting as well, your shoes aren't fitting as well, or jewelry is kind of harder to put on. You may feel that part of your body is visibly larger than the other. You might notice tightness in your joints or stiffness with some of your movements. You might also notice a feeling of puffiness or fullness in that arm and that leg typically. Changes in skin texture can occur, so dryness. You might also get some sensory changes like burning or itchiness. And again, if you think about kind of how we just talked about what the lymphedema is it's taking up more space. So with those sensory changes, you might be getting some kind of impact on the nerves, and that's why you're getting that itchiness and burning sensations. So we're going to look a little bit further about the different stages of lymphedema, starting with stage 0 and stage 1, and then we'll kind of look at stage 2 and 3 in a little bit. But stage 0 lymphedema is really subclinical lymphedema, so it's a concern for the impaired lymphatic flow. And then stage 1 is spontaneously reversible and typically marked by pitting edema with an increase in limb size and more of that heaviness. So when I say pitting edema, kind of for reference, if you've ever thought about, let's say someone has a swollen leg or anything like that, if you were to kind of imprint your thumb into their leg and it kind of lingers, that's what that pitting edema is, so it's not going to rebound back as quick. And it's really been seen that working with individuals who may be experiencing these early stages, stage 0 and stage 1 lymphedema, are really considered to be the most ideal time where we're most likely going to see their symptoms reversed. So we typically think of that, again, that stage 0 as the subclinical lymphedema. You're not going to see as many outward signs of the lymphedema, but there's definitely the lymphatic system is impaired and some changes over time are occurring. And these individuals may start to feel those early signs of heaviness or achiness. And then that stage 1 lymphedema is where you're really first seeing the swelling outwardly. You might actually see a change in the size of your arm versus the other arm, or the size of your leg versus your other leg. But often these individuals will feel their swelling improves with rest and elevation. So there's that fluctuation period with these early stages. So the American Physical Therapy Association Academy of Oncology PT really looked at the research related specifically to breast cancer lymphedema and found that early identification of these subclinical lymphedema is in high-risk groups really improve better outcomes. So what that means is we kind of really are looking at these risk factors that people are going through and getting them set up with early intervention for these at high-risk groups have really seen an improvement in lymphedema and the decreased likelihood of occurrence. So previously, when they weren't doing what's called this prospective surveillance model or planned scheduled visits with a healthcare provider during your first few years of treatment, we were seeing these people progress into later stages of lymphedema. But now that we're kind of getting these early diagnoses of lymphedema, we're able to treat them well and prevent them from progressing into these later, harder manageable stages. And so lymphedema, while it can develop over any time throughout your lifetime, it's really most common to develop in those first 3 years of your cancer treatment. And that's why really prospective surveillance model is recommended during these first 3 years. So getting those early identifications with your healthcare provider, having them set you up with a rehab therapist to kind of monitor those changes in those first few years are really important. Other treatment includes education on how to know your risk reduction strategies, be able to form self-massage or wear compression garments if determined appropriate for you. And then lastly, one of the most effective ways to treat all stages of lymphedema is exercise. So both exercise, both aerobic and strength training are really beneficial in reducing the risk of developing lymphedema and decrease the impact lymphedema has on your daily life. You should start, like my general recommendation is starting with low weights and progressing slow so we're not overloading that already impacted system. And again, a cancer rehab therapist is a really great person to help kind of establish that good exercise program that's going to be really specific for you. So you can see that there's a person here with lower body stage 1 lymphedema and then a person with stage 1 upper body lymphedema. And it's really important to know that it can be the whole limb or just part of the limb. So with the person's arm, the arm is more affected than the hand, but it can also be the hand and not the arm. So it kind of can express in different ways. And it can also not necessarily be the arm, but more in the chest and back as well, kind of depending on where that really insult to the lymphatic system lies and how someone's body is able to filter those toxins. So exercise, as prescribed and monitored by a therapist, can, again, be really, really beneficial as you go through or even after your cancer treatments. So exercise allows to use the muscles, kind of act as a pump to help drain any excess fluid. So in the very beginning of this talk, I kind of talked about the superficial and the deep system. So the superficial system really helps with some of that. If you've ever heard of the manual lymph drainage, try to get that going through the superficial system. But then also the exercise helps work that deeper system by really getting that muscle pump kind of around all of those tissues to help filter fluid back up through the body to excrete. And it's really a myth that exercise and strength training increase your risk of developing lymphedema, but rather allows for improved range of motion after surgery, improved overall strength and weight management, all of which are contributing factors to have a positive impact on the lymphedema risk reduction. So again, a cancer rehab therapist is going to be really the one to help design a specific exercise program for you that's really personalized to you and what you need based, again, on all of your side effects that you might be going through through your cancer journey or after, because not every one program is going to be cookie cutter and the same. We're really going to individualize them. But for like a general recommendation of, I guess, exercise to think of, like when you think of what is like a decongestive exercise for lymphedema, is anything that you're using the muscles to kind of help pump fluid up. So doing some walking, doing some marching, doing some heel raises, all those things generally for the lower legs are been helpful. And then for the upper body, general things like doing light bicep curls, rows, things like that. Anything where you're pushing, pulling, again, getting those muscles to be active to help move fluid are really going to help you kind of fight that gravity. Again, because gravity works against us every day, and so it's going to kind of use the muscle pump to get all that flow back up. So now we're going to talk a little bit more about the later stages of lymphedema, so stage 2 and 3 lymphedema. So stage 2 is that moderate stage where there's an increase in fibrosis, and then stage 3 is that most advanced stage where no pitting edema is present because of the increased fat and hardness of the skin. So now when I was saying that pitting is no longer present. So now the limb is going to look a lot bigger, but it's going to be really firm. And you're not going to be able to leave that imprint just because of all of that kind of stagnant fluid that's kind of hanging out there is really just kind of stuck and it isn't moving. So with stage 2 lymphedema, this is really the beginning of progressed advanced chronic lymphedema, where swelling is really now consistent in the tissue, and you're getting changes in texture and noticeably progressing worse. So it's no longer kind of fluctuating back and forth. You're just going to continue to see progressions. And this really requires a more extensive treatment plan intervention to manage both the acute and long-term side effects through the complete decongestive therapy, which I'll talk about in a moment, which is a combination of the manual lymph drainage, compression, bandaging, and exercise. And these individuals typically require a more long-term use of compression garments to manage their condition. So now stage 3 is that progressive disease with tissue thickening, hyperpigmentation, or changes in kind of the skin color, changes in skin folds, or we call lobules, so you're losing the architecture of kind of your arm or your leg. And then you're also getting skin texture changes with kind of funky growths, dryness of the skin, things like that. Really the key with stage 3 lymphedema is you're not really having just a lymphatic disease anymore, but you're having skin disease as well. So you're seeing changes in other body systems. So I want to kind of take a look at these pictures. You can kind of see that these arms and legs and limbs are quite a bit bigger, and we also see other changes in color, limb shape, and kind of deformity. So we want to kind of talk about how will this impact a man or woman's function. So if we zoom our eyes into the person on the far right, you can see that their left leg is quite a bit larger than their right. So this can really impact how joints are moving, her ability to walk, her ability to change position, and kind of get dressed. So I'll use the example, I have a 3.5-year-old daughter, so she's at daycare all day. So imagine that this person works at a daycare. It's having higher stages of lymphedema. It's really going to impact her ability to kind of get up off the floor, walk, run after children, pick up children, really participate in all these things that she needs for her daily life. Many people with progressive lymphedema have really adapted to life with this advanced stage, but they still require daily self-management to keep their limb healthy and active through exercise, through proper skincare, through use of compression garments daily, and even at night. So there's a couple different ways that we use compression for these later stages. So for stage 2 and 3 lymphedema, the treatment is known as CDT, or complete decongestive therapy. So it really should be performed by a certified lymphedema therapist like myself to ensure proper use of the manual lymphatic drainage, the compression bandages, and the exercise. So I'm going to kind of review a little bit more about each kind of phase of this. And it's important to note that with these later stages, there's kind of like a 2-phase component of CDT. There's this initial phase where it uses the short strip bandaging to kind of get that limb to be smaller. And then a lot of these components are still the same in the second phase, except instead of the short strips bandages, they're using more compression garments. So the first kind of aspect of this wheel here is good skin and nail care. So we really want to ensure that the skin is clean and free of potential infection and breakdown. And we use like an alcohol-free lotion to apply to the skin to ensure hydration kind of as we go through all these stages. And this is really done like in a single session with my patients. And then there's the manual lymphatic drainage, also known as MLD, which is a really light touch massage, and it moves the lymphatic fluid from an area of impaired area of the body, like your arm and your leg, towards a non-impacted area of the body. And with the MLD, I'm usually using a really light touch, and I'm thinking about like stretching the skin a little bit, because again, with that superficial system, those lymphatic vessels live really not too much under the skin, and so by stretching the skin and not pressing down, you can actually open those vessels and allow for better fluid movement. So I'm kind of working my way from the lower part, so again, I'll use the arm example, kind of clearing the system, but working always up and across the different areas to kind of really move that lymphatic fluid out of the impaired arm or leg to help kind of use the body's other lymph nodes throughout the body to kind of help improve that lymphatic flow a little bit. And then after I do the manual lymphatic drainage, then we'll use compression bandaging with short stretch bandages where we layer the cotton foam and then these short stretch bandages in quite a lot of layers, and so it can look pretty cumbersome. It almost looks like a very large cast on someone, but it's like if you think of like a soft cast is the best way I kind of visualize it to people. But that helps really decrease the size of the limb and help improve lymphatic flow. And then after I'd wrap the arm or the leg, then we do, again, decongestive exercise. So any exercise that we're going to get those muscles to kind of pump and, again, help with more fluid movement. And so all of this can happen within a single session. And it's really important to know that with these later stages, we can still kind of get the limb to be a little bit smaller to what's more conducive to the person in their daily life to, again, help reach their goals. The standard care plan for this kind of intensive phase is 5 days a week, where I'm doing the skincare, I'm doing the manual lymph drainage, I'm wrapping the leg, I'm giving exercise both in the clinic and at home, and then every day for 1 to 2 weeks they come back to kind of help continue to get their limbs smaller. And then we set them up typically with what's called a custom compression garment to help maintain that same size of the limb that we got, where they can live kind of an easier mobility life, let's say with the leg. Typically, I've been seeing more patients with kind of lymphedema of the legs because now with again, that early detection, we're getting the earlier stages of swelling in the arms for breast cancer. And so I'm not having to do these later stages. But for legs, we typically, will see, someone might see it start, hoping it goes away, doesn't go away, it starts progressing. And one example is I had a patient recently who had a very, very large leg, and they came in and they just, were hoping maybe it would get a little bit smaller so they could move around a little bit better. But within 2 weeks, we were able to take 2,000 milliliters of fluid off the leg and get it smaller, and they didn't realize how much it was truly impacting their function until they saw that decrease, saw the movement improving, saw their stamina even improving even while they're going through cancer treatment. It's really important to know too that these later stages, there's a lot of things we talk about, kind of the fluid, that not all swelling equals lymphedema. When I'm working with these patients, I'm definitely checking all these risk factors, such as I'm making sure that there's no kidney or cardiac dysfunction because we don't want to overload those systems either. And I'm really making sure that I'm meeting their goals, but also taking consideration into everything else they have going on within their cancer journey, all their other side effects and things like that, to really make sure that we're making it as beneficial for them as possible. And it's not just, this is my treatment plan, you're going to go along with it. We make sure everyone's on board kind of with what's going on. It's really important to note that supervised and dose-based exercise kind of in this plan is really going to help, again, decrease the risk for lymphedema and promote quality of life, kind of as I was saying. And that not all cancer rehab therapists treat these advanced stages, but all are able to assess and refer to the right person to manage these symptoms. So I'm seeing all stages of lymphedema because I'm a certified lymphedema therapist, but we have a lot of cancer rehab therapists that will see and treat these stage 0 and 1 with some of these basic risk reductions that I'll talk about here in a minute. And then if they're seeing that someone has these later stages, then they're referring to me so I can do more of this kind of specialized treatment plan. It's also important to note that in more of these advanced stages of lymphedema, there are some new surgical options, including venous bypass, liposuction, or lymph node transfers. And these surgeries are performed by a specialized trained surgeon who would do these surgeries, and that really needs to be assessed as a candidate for each surgery for that person. But there are kind of new treatment modalities out there. And I've seen a couple people who've had a lymph node transfer, and then they come see me because they'll still need care. It's not going to be a fix-all, but it's a way to a lymph node transfer is kind of a way to get other lymph nodes there to help improve that fluid for lymph nodes that were removed. So again, I've mentioned a little bit about the education and the important part of all stages of lymphedema, but it's really important to know that education and how we can use that to kind of improve our risk reduction practices. So the first step is early detection. So again, being aware of those early signs and symptoms of lymphedema, which again include the heaviness, the feeling of fullness, clothes, jewelry not fitting well, itchiness, tightness, all those things. One of the best ways of kind of going about this is to seek a cancer rehab therapist before you even start surgery or radiation. And that way we can get baseline measurements and be able to monitor any of these changes after surgery and then as you're going along through all your different treatments. And then if you're past this phase of your journey, it's really never too late to be seen and kind of get evaluated so we can kind of get those baseline measurements and still follow you and monitor changes over time. Step 2 is really to have good skin care. So this again reduces your risk of infection, which is a risk factor. And if you get a scratch or a cut, you really want to make sure you clean the area, cover with a bandage to prevent that infection. Wearing gloves, long sleeves, and pants while gardening can be really helpful to prevent any sort of cuts. Wearing bug spray and sunscreen are also good practices to protect your skin outdoors, as well as keeping your nails clean and trimmed and applying lotion to help kind of avoid cracks in your skin. Anything again that they talked about introducing an infection or possible infection through that skin barrier, we're kind of trying to mitigate that a little bit. And then step 3 is again maintaining a healthy weight. So I had mentioned that the higher body mass index of or BMI of over 25 is a risk factor developing lymphedema. So just keeping active and normal weight are critical. And activity doesn't have to be, 45, 60 minutes of full-on exercise every day. Even just like starting with a light walk and things like that are going to be helpful and kind of build those healthy habits over time. But exercise is that step 4, and so we talked about it a little bit. And again, it will always just help with reduce the risk and severity of your symptoms of developing and progressing to later stages of lymphedema. Step 5 is wearing a compression garment if deemed appropriate by your healthcare team. And so this should only be determined after assessing your risk for developing lymphedema. Kind of a general recommendation is with these higher risk patients, if they have a higher risk factor, if they have, more of those 4 lymph nodes removed, if they have history of radiation or planned radiation, if they have a previous infection, I might be setting them up with a light compression garment to kind of help prevent the lymphedema from progressing into later stages or even developing, because you're having that external force to kind of help with that lymphatic flow. But then these stage 2 and 3s, that's going to be really where you need to have a compression garment that's going to be a higher compression level to kind of help maintain that limb size, because again, those are progressive stages, so the limb will continue to get big if it doesn't have an external force against it. And then the last step is step 6, which is those regular medical checkups. So you really want to report changes in at-risk areas to your cancer care team, because this early detection will really help with the early treatment if you develop that swelling. So now that you know a little bit more about the lymphatic system, cancer-related lymphedema, and its treatment, kind of when would you seek care from a cancer rehab therapist? The answer is really any time. We're always here to help. A therapist can evaluate your risk, really build a specific exercise plan and strategies to help build those healthy habits and get you to that destination. You really should, again, seek care soon if you're experiencing those feelings of heaviness, achiness, fullness in the affected area, the stiffness or decreased flexibility in the joints, clothing and jewelry fitting tighter, and persistent swelling after surgery of more than 6 to 8 weeks. So we know that there's going to be some post-op swelling. So typically if I see someone before surgery and then I see them after, I'm not going to assess the size of their arm or their leg at that 4-week appointment, let's say, because I know there's still going to be some post-op swelling. So I'll wait until that 6 to 8 weeks to really see if I see a true change that's indicating more of that lymphedema versus just post-op swelling. Early diagnosis and treatment is really the most effective for reducing the impact of swelling on your daily life. So we're, as a cancer rehab therapist, me and my colleagues, kind of throughout the Puget Sound and everything, are really here to help you do what matters most, help you achieve your goals, help create a really personalized treatment plan to help you not just through lymphedema, but through any kind of those adverse effects that have been talked about today that you've experienced, to help you just live your best life and really thrive beyond your cancer diagnosis. So thank you so much for the time to be able to speak with you today. And I will say I didn't put any of my contact information here because I kind of went through a little transition. But I am now with Olympic Sports and Spine. So, and we have quite a few therapists, cancer rehab therapists that work in multiple locations to help kind of get you where you want to be. Are there any questions?
Yeah, we do have like a full 10 minutes for questions, so I'll take this side of the room. Jill and Marika will take that side of the room and the back of the room. So, where are we starting? Right there.
Hello. Hi. I've heard with lymphedema, like you're not supposed to get blood pressures and blood draws, but also is there new research maybe saying it's okay?
Yeah, so they've kind of seen new research that it's not going to throw you into advanced lymphedema. It's not going to create lymphedema. The biggest recommendation they kind of talk about is like they say it because people will take it to the extreme. So they don't want you to have blood pressure. Let's say you get hospitalized and you have a blood pressure cuff on that arm and it's taking it every 10 minutes. That's going to call, insult over injury of your system and kind of impede flow. But every other kind of blood pressure that you take, needle sticks and everything like that is not going to be the one thing that kind of sets your system kind of into progressive lymphedema.
I had lymph nodes removed under my right arm.
Mm-hmm.
Can I get lymphedema in the leg? Does it work like that?
So I've had kind of some kind of unusual cases recently where I'm seeing a little bit more of like a systemic kind of thing going on. And so knowing that chemotherapy kind of affects the whole body, things like that, there's new evidence that shows like taxine drugs can kind of increase your risk for developing lymphedema. So like Taxotere, things like that can definitely increase the risk. So it's not unheard of. It's not as likely but your body is affected. So if you have more of those risk factors that are more systemic, it could happen. Yeah.
I was told at the very beginning I had lymphedema and probably one or two, but I was told that you couldn't use the hot tubs or sauna rooms or steam rooms. The last conference I was in, they said, not really, that doesn't matter, it doesn't make any difference. So which one is it? Yeah.
So I think, it really, kind of taking everything with a grain of salt, because we live in a world of gray. It's kind of what we're all taught in PT school. There's no one thing or the other. So the kind of where they were talking about that before was heat kind of increases what we call vasodilation, blood flow to the area. So if you have swelling and blood flow comes to that area, it can kind of promote a little bit more. But again, it's that kind of how long are you subjecting yourself to that? So if you're going to be, a short period of time, then it's not going to be as likely as someone who's going into a hot tub for 30 minutes every single day, using a sauna all the time, kind of here and there. It's kind of just healthy, a healthy lifestyle, healthy eating. If you eat all this bad stuff all the time, it's going to affect you. If you have one little thing, every once in a while, it's not going to be as big of an impact.
In terms of flying, do you recommend a sleeve and a glove preventatively, or is that now contraindicated?
So it really, the sleeve and the glove kind of combo, so it really, again, depends on how many risk factors you have. So if you're at a higher risk and you're already it's already recommended that you wear a compression sleeve, then wearing a compression sleeve while flying is going to be that best bet. If you have swelling in the arm or the hand already, wearing that glove and that sleeve are going to be really beneficial. But if you have very little risk factors, you don't have a sleeve already as determined by your healthcare provider, then it's not something that you have to go out and try to figure out yourself, because there is specific kind of fitting and recommendations, even for those ready to wear, something you can buy off the shelf kind of garments. Yeah.
I had two questions. Yeah. One question, you mentioned that jewelry fitting tightly on, rings, that can be an early sign. Mm-hmm. I know I've been having that sign for a couple of years. I got remarried in 2021, and I resized my wedding ring so many times. Finally, I just don't even wear it anymore. Is that possibly an early sign of lymphedema, or could it just be, because it seems to change somewhat depending on what treatment I'm on too?
Yeah, so it can, because again, your body is being introduced to all these, different things, and so some things are going to promote more of that, swelling, water retention, like that, but it definitely could be, and so I really recommend people thinking of let's say that kind of early sign or symptoms along with others. So if you've also noticed that man, it just feels like I have a harder time getting my sleeve on, my shirt, with a long sleeve on that side, just feels a little bit different, or you feel like that hand is a little bit more achy and it never used to be, that along with kind of the rings not fitting tight might be some of those early indications and worth getting checked out.
And then the other thing, is it possible to have, do you have any lymph nodes in this area, like in your abdomen?
Yeah, there's a lot of lymph nodes in the
So
abdomen.
is it possible that, because I have one side for some reason that's starting to bulge out and the other side is not, could that be lymphedema as well?
That would require a little bit more kind of investigation to kind of really figure out. Typically, we'll see like the abdominal or trunk swelling if there's been radiation to some of those lymph nodes, if there's been lots of lymph nodes removed. Typically, I'll see abdominal swelling a little bit more with cancers involving like pelvic lymph nodes being affected or abdominal lymph nodes. For
Ovarian
example.
cancer?
Huh?
Ovarian cancer?
Yeah, it can be with like radiation, surgery, all of that. A tumor pressing in on to lymphatic vessels can kind of cause lymphedema as well. So all those are kind of possibilities. Maybe worth kind of just getting things checked out. So there is direct access in Washington, but with knowing how many factors that are going on with the cancer care team, how many different doctors you're seeing, all of these different therapies, we typically recommend getting a referral from the doctor just so they know where you're going. And that way we can have really streamlined communication with the doctors. We really try to make sure that we're keeping in contact with the doctors, giving them progress notes, letting them know what's going on. So everyone's kind of in the same loop and we're on one cancer care team. And we feel like that way just everyone's getting kind of the best kind of instruction.
All right, we have a question over here.
My question is, I have non-Hodgkin's lymphoma, and recently I had chemotherapy, and I noticed like my shirts are tighter around my neck than they have been, and my knee and my ankles just feel like they're tight, the skin gets tight. Can chemotherapy cause that kind of lymphoma? A lymphedema, I mean?
So certain chemotherapies can predispose you to increased risk for lymphedema. That's kind of some newer research. Whether or not it's that same thing is kind of, again, there's so many different things at play. I know with Dr. Rosales talking about the immunotherapies and itises and arthritises and tightness, things like that, we kind of have to tease out kind of what is and what isn't. And so that's where kind of those evaluations where we can really take more time to kind of delve into the information and really figure out what's truly going on.
How would you evaluate that?
So I would ask more questions, find more about your history, kind of really figure out what's going on, how many rounds of chemotherapy, what other treatments you've had, your current function, your previous function, all these things. We typically have like 40 minutes, sometimes to an hour where I really like dive deep. And then we see people multiple times a week to really kind of figure out what's going on, which is nice because I get a little bit more face time with my patients than some other providers do.
Is this something that they need to request a referral to you to get the diagnosis, or do they get the diagnosis from their doctor and then just referred you for treatment?
So it kind of goes both ways. Sometimes I'll get referrals just with their cancer diagnosis, and they might say at risk of lymphedema or early signs, or they just say swelling sometimes, and I look at that. Other times I'll get a specific referral for lymphedema. It kind of just depends.
So endometrial cancer, if a lot of lymph nodes were pulled during that process, if one then is active and say hiking and in heat or strenuous exercise, you always swell like above sock lines and such, is that something to be concerned about, or is that just the heat and the exercise, would you say?
That's something I would probably kind of want to look into a little bit further. I've had a patient before who's very active, who had a lot of lymph nodes removed, and knowing that their history, I kind of recommended some compression garments for them to wear while they're being active, while they're running, to kind of help just prevent that swelling. Because again, if you're seeing those fluctuations, it could be an early sign. Again, we have to check out, with other factors, but yeah.
All right, we've got time for one more question. One more question.
Yes, up there you listed prostate cancer as being, so where would you see lymphedema with prostate cancer?
Typically you'll see it in the legs, typically sometimes in the abdomen a little bit, again because of where radiation, where surgery was, it's going to affect those pelvic lymph nodes or inguinal lymph nodes. And so let's say there were some lymph nodes taken or affected on the right side, we'll likely see right leg swelling, and then that's where we would manage it.
Thank you so much. Round of applause for Mackenzie Jackson one more time.